This is about ultrasonography basics and interpretation. So class is divided into basics and interpretation. Moving on to basics. History. The use of ultrasound first in ophthalmology was done by Moon and Hughes, American ophthalmologists. They utilized A scan to measure intraocular tumors. Further, it was expanded by Okoshala. And in 1958, Baum and Greenwood, they designed the first two-dimensional ultrasound instrument. Followed by in early 1960, Janssen et al. He utilized A-scan to measure the distance between structures in the eye. And followed by the most important step, which was taken by Oshoinik, he standardized ultrasonography so that report from one part of the world can be interpreted in the other part with standardization. And in 1977, Coleman et al., they first performed the immersion B-scan, followed by, 1970s, Doppler came into the normal ultrasound, which was applied in ophthalmology also, followed by color Doppler. In 1919, Pavlin, they developed a high-frequency ultrasound. So we are going to basic physics. What is ultrasound? So we are moving on to the basic physics. What is an ultrasound? It is just a normal sound wave, just like I'm talking. It is also a sound wave. But only thing is the frequencies are more than 20,000 hertz. So it is not audible to human ears. So basically a sound wave, ultrasound is propagated as a longitudinal wave, which passes through a medium. As it passes through a medium, it causes compressions and rarefactions of the molecules in that medium. So as the wave passes through a media, as it passes through two media, where there is difference in sound velocity, that is acoustic impedance, part of the wave, it gets reflected back. That we call as echo. This holds good for any sound wave which travels through two different media of different acoustic impedance, part of which is reflected, that is called an echo. So what is an acoustic interface? When there are two media of different acoustic impedance, their echo is created. So the acoustic interfaces are the sources of echo. As we could see, this is a media 1 with low density and media 2 with a medium density. Here the difference between the acoustic impedance is less. So the intensity of the returning echo is less, or it's a weaker echo. Whereas here, the difference between the two media, the acoustic impedance is more, so the strength of the returning echo is more. This is exploited in ultrasound for tissue diagnosis. So the acoustic impedance of a particular media is defined as the sound velocity multiplied by the density. And the law of acoustic energy says that angle of incidence should be perpendicular to get a angle of incidence is equal to angle of reflection. So which we apply here. Whenever we use a B-scan, if the probe is perpendicular to the structure interested, we get a proper echo from that structure. If the probe is not perpendicular, if the sound beam is not perpendicular, the same IO of B or a high reflective structure may not produce the echo anticipated. So like any sound wave, this ultrasound also undergoes absorption and refraction. So the returning echo may also suffer all this. So the next we are talking about frequency and velocity. So as I already told, ultrasound is more than 20,000 hertz. So the frequency which we commonly use in ophthalmology is 8 to 12 megahertz. The thumb rule is that as the frequency increases, resolution increases, whereas penetration decreases because the wavelength is reduced. So this is, and vice versa. Hence, in a UBM, where there is high frequency, we have a better resolution of anterior structures, but we do not see the deeper structures. Whereas in a normal B-scan ultrasound, the frequency is much lesser than what we use for UBM. The frequency is 8 to 12, and here it is like 40 to 80, 50 to 100. So here, we are not able to see the anterior structures with a better resolution, but we do see posterior structures better than UBM. And the velocity. So here I have enumerated the velocity of the ultrasound as it passes through different media. So this is important in biometry, and as well as certain features, artifacts which may encounter are also explained by this. So what is the basic design of an ultrasound instrument? So here we have a display kind of thing, and here is the patient. Here is the probe, which I am putting it as transducer. So there should be a source of an echo, that the source of the pulse, ultrasound pulse, which is the pulsar, and then it is carried through the probe. This is the transducer. Transducer, it carries the ultrasound signal, and it also carries back the reflected echo. Then there is a receiver, wherein the signals are processed and it is displayed in the display screen. So the basic principle is, as I told, it's a pulse echo. So there is a transducer which is inside our probe, which sends pulses of ultrasound to the tissue. There we encounter multiple tissue interfaces, so multiple echoes are returning back, which is again received by this receiver inside the transducer. So this is what is happening inside the transducer. This is the pulse echo principle. What happens actually is what we use is called as a piezoelectric effect. We'll start from reverse effect, because that is how it works. We apply an electric current, which causes compression of the piezoelectric crystal inside the transducer. This mechanical compression causes the piezoelectric crystal to generate pulses of ultrasound. So this we are sending to the tissues, the echo is reflected back. And as soon as the sound echoes come, again they cause the actual piezoelectric effect, again compression of the piezoelectric crystals. Now this time we generate electrical signal, and that is amplified. This is how the ultrasound works. So signal processing. So we have done with the transducer, now we are moving on to the next part, there's a signal processing. So there are multiple processes like amplification, compression, compensation, demodulation, rejection. But the most important thing which is happening is amplification. There are 3 types. What the initial ultrasound, even A scan, we were using this linear one. As we can see, the linear one is very sensitive even to fine changes in the echo. But it doesn't have a wide spectrum. Whereas the logarithmic one has a wide spectrum, but it may not be very sensitive. The S-shape which we are using now, the standardized echography, S-shaped amplification is used, which has the advantage of both linear as well as logarithmic. It has a wide range, but is also sensitive to changes which happen at very low intensities or at very high intensities. So few terminologies we are supposed to know. The axial resolution, which is defined as the minimum distance between 2 echo sources. It is 100 microns in B scan and 37 microns in UBM. So UBM has higher resolution. Even that minimum distance it's able to detect. So what are the factors that axial resolution is dependent on? Frequency of the sound is the most important. Higher frequencies is translated into higher axial resolution. Shape of the crystals which is now used, all those high focused ultrasound is a concave one, which causes a very focused beam. So the axial resolution is increased. As well as the dampening material. The dampening material is present at the back of the piezoelectric crystals. It helps in delivering the ultrasound in ultra short pulses, very short pulses. So that's how the axial resolution is improved. So the gain. So what is the gain? It is a unit of relative amplification. Actually, it is a sensitive setting which is expressed in decibels. So it actually changing a gain does not change the intensity of the reflected echo. It is very important to understand this. We are not actually changing the echo of the tissue by changing it. We are just changing what is displayed on the screen. So here one could see optic nerve drusen. This is with the normal gain, like gain 0. It is not appreciable. I mean, seen but not very much appreciable. When the gain is reduced to -44, we are able to appreciate. So what are the structures we should look for in low gain? Or when you will reduce the low gain, to look for what? So whenever we suspect all high reflective structures like optic nerve drusen, normal choroid, sclera orbit, and also intraocular foreign bodies. And whenever there are vitreous opacities, very few opacities, we are not very sure. In that case, we may increase the grain so that the opacities become more visible. The next phenomenon is the time gain compensation. What is the time gain compensation? It's a mechanism in which echoes returning from nearby tissues are decreased or suppressed so that the echoes coming from far structures are seen better. Initially, it was like we have to do manual thing. the recent missions which all have inbuilt time gain composition. So in this, the first picture shows I have not on this time gain composition option. So we are getting an image like this. So here I have put the TGC on so that what are all we have to take from, this is the probe line. From here, the gain is reduced to the near structures by -41, then mid structures by -38, and far structures by -31, which means more, the gain is reduced more for the near structures so that the far structures are seen better. And it is very useful for orbital study. So what are the different scans? There is A scan or amplitude scan and a B scan. I'm going to talk about B scan mainly. A scan, I'm just a word about it. So A scan or an amplitude scan, it is unidimensional. Here, there is the echoes are expressed along the long axis with time along the horizontal. So there are two types, biometric and standardized. Biometric is the one which is used, which has a linear amplification. So biometric, the frequency employed is 10 to 12. It has a linear amplification. It is very sensitive, but doesn't have a wide spectrum. And it is used mainly for axial length calculation, which is used for IOL power calculation. So the standardized one, which is combined with the B scan, which we use routinely, it has an S-shaped, and it's mainly used for tissue sensitivity. So this is the first spike is the cornea, followed by lens, anterior and posterior capsule. Then here is the retinal spike and choroid. Sorry, retinal spike and the sclera. Then orbital tissues have very low spikes. So the B scan is the brightness scan or a two-dimensional scan. Here the spikes have, the echoes have both vertical and horizontal orientation. So we get an idea about the shape, structure, and size also of the lesion. So it is two-dimensional. The frequency used is, here we use is 12 megahertz. The amplification used is S-shape. So the standardized echography is the term used for standardized A scan with contact B scan. There is another type is called immersion B scan, which is done with a coupling fluid. The dots which we see on the screen are actually the echoes. The brighter the dots we see, the more intense is the echo. So what are the indications? Of course, in opaque media. Other than that, in a clear media, when we have to measure the choroidal thickness or when we have to have a differentiation of intraocular tumors and any optic nerve abnormalities like drusense, and even in an oil-filled eye when we are not sure whether retinal detachment is there, and even in Sturge-Weber syndrome where diffuse choroidal hemangioma we may not be able to appreciate, and also for extraocular movement study and orbital study. So how we go about it? So before beginning a scan, we should go through the history and clinical examination. Possibly we ourselves do an examination, and then we should go for the basic positioning and patient preparation. We should explain to the patient. Usually it is done in a supine position. Certain conditions where we have to demonstrate a shifting fluid, or when there is an intraocular tamponade, maybe we can do in sitting as well as supine. And it is usually done here with the closed lids, but we can also do with the open lids. Open lids, the advantages is the attenuation by the lids is avoided, but we need a topical anesthesia, maybe little discomfort to the patient. And with closed lids, it's very much possible to do, but the thing is, a few signals may be attenuated by the lids. In case of tumors, ultrasound is mainly used for diagnosis, differentiation, as well as follow-up. And in case of trauma, to look for the posterior, like examination of posterior segment. And whenever there is a hemorrhagic CD, we follow up the patient for clot lysis, presence of foreign body. Whenever there is a PDR or a TRD, we look for PVD status. So the indications are going on and on. And recently, we are using ultrasound-guided subtenon injections, ultrasound-guided anesthesia, though not very popular, are done in few parts of the world. Sir? Yes, sir. Oh, okay. Yes, sir. So I mentioned as choroidal thickness. Okay.
There's one correction here. You have written retinal detachment, oil-filled eye. You will do ultrasound. If the media is clear in an oil-filled eye, it would be better to see the fundus.
Yes, sir.
you will not be able to find out the retinal status on ultrasound
Yes,
in an oil-filled eye.
yes, ma'am.
So in an opaque media, probably you can still order ultrasound, but in clear media, there is no role.
Okay. So this is the B-scan probe. It consists of transducer. The most important thing about the transducer is that it oscillates along the plane of the marker only, either towards it or away from it. So the display will have the probe. Okay. The display, this is the probe tip. This white line corresponds to the probe tip. And whatever is the superior part is the one which is adjacent to the probe tip. And the inferior one is the one which is 180 degree opposite to the probe. This, it will be seen in the next slide. So there are different probe orientations. So this is the axial scan. So in which the probe marker is usually placed nasal, and the lens and the optic nerve should be centered. And it is most useful for assessing optic nerve head disorders, subtenon widening, and T sign and all that. And it's also vertical and horizontal. And vertical axial is performed with the probe up. The transverse scan or horizontal scan. It is mainly useful to determine the lateral extent of any lesion, be it a detachment or a tumor. So here, this is a transverse or horizontal scan. We are scanning the superior quadrant, and the probe is placed nasally. So the transducer, it oscillates parallel to the limbus. That is what the only thing we should remember. And we are scanning the superior quadrant, lateral extent we are assessing. And the probe is placed at the limbus. We are seeing lesions posterior to the equator. The probe can be swept like back and forth from limbus to fornix. When we are in the pharynx, we are looking at the anterior to equator. So it is just 180 degree opposite to where we are.
Can I just clear this point? I don't think people would have understood.
Yes.
Basically, there is a mark on the ultrasound probe. Can you show that mark? I think one of the slides that mark will be there.
This.
Okay, it's not very obvious, but there is a mark on the ultrasound probe, and whatever you see at the superior edge of your image in the display, that belongs to the side where the mark is kept. So if your mark is nasal, then what you see in the image superiorly, it's actually nasal. So okay. The other will be opposite side. So the inferior area what you see is actually temporal. Okay. So the superior belongs to the mark, wherever the mark is. If your mark is superior, then you are seeing superior in the upper edge of the upper image, and then the lower will be inferior.
Yes, ma'am. So these are the various transverse scan for superior. The only thing is, if you are scanning a superior quadrant, the patient should look up, and the probe marker is nasal, and we are moving from the limbus to fornix. That way we can remember, I think. And this I already told, like when we are at the limbus, we are scanning posterior to equator, and we as in move the probe towards the fornix, we are seeing the anterior quadrant, 180 degree opposite. So this is a longitudinal or vertical scan, wherein this scan is useful for measuring or looking at the anterior-posterior extent. So especially the specific clock hour in a tumor to see the anterior-posterior extent. So here, the probe marker is facing towards the meridian of interest, and we try to see the anterior-posterior extent. It is a longitudinal scan of 12 o'clock. So this is a choroidal malignant melanoma, wherein a transverse scan, so it is scanned like this to see the mass here, and we are measuring the transverse basal diameter and the height. I'll be dealing with this again. And this is a longitudinal scan to that quadrant. So it will be like this, and the mass is seen. Ideally, a longitudinal scan should have optic nerve head cut, but here I think the probe has become more towards the fornix, so the optic nerve head is not seen. So what are the recent developments? So there is a high frequency ultrasound, This is achieved by using the transducer. It consists of newly developed lead bicarbonate and sol gel molecules are used, which produce more focused beam. And Doppler ultrasound, like in other ultrasound, we are employing here based on the movement of the RBCs. And we are utilizing to see the flow in the central retinal arteries, veins. It is used in the evaluation of keratoid cavernous fistula, even internal vasculature and tumors. Harmonic and superharmonic ultrasound is based on nonlinear interaction of the sound wave in a media. And contrast-enhanced ultrasound involves injection of ultrasound contrast agents like microspheres of air or fluorocarbon, and then performing an ultrasound. This is also used in evaluation of vascular lesions and tumors. And compound spatial imaging is scanning a particular area at multiple angles. And this also indirectly increases the resolution. And it is more useful for evaluating optic nerve head and retrobulbar lesions. And three-dimensional ultrasound gives idea about the tumor volumetric analysis, since it gives the third dimension. And 4D scans are nothing but combination of multiple 3D scans. It is used mainly in prenatal diagnosis of Anophthalmos, Microphthalmos, and now they are recently developed for Retinoblastoma as well. And C-scan ultrasound is used for optic nerve evaluation. And there is high-intensity focused ultrasound. It has more of a therapeutic value. It is used for treating failed blebs, very small intraocular tumors. So this is a compound spatial imaging. This is a conventional, only single linear imaging. Here, there are multiple electronic beams are used to have a compound imaging. This is a contrast-enhanced ultrasound. And this is a 4D ultrasound showing an ophthalmic socket. And this is the C-scan imaging. And this is a power Doppler showing vasculature in intrinsic vasculature in a melanoma. So interpretation part. This is the normal scan in which we can see a oval hyperreflective structure lens. And its internal, the intensity of the internal echoes depends on the degree of the cataract. And next comes the vitreous, which is usually anechoic, especially in children. Few low reflective echoes can be present in adults, depending upon the amount of syneresis. Usually, retina, choroid, sclera are seen as single high reflective structure. They are separated only in pathological conditions. And then the orbital structures, or they are not very much seen because of the attenuation. So this is an axial scan. This is a transverse. Both are transverse scans, superior and inferior. So when we describe any lesion, we describe in terms of topography, which means location, extent, shape of the lesion, configuration, and structure. Then comes the quantitative, which is the actually A scan, wherein we talk about the reflectivity, high reflective or low reflective, then about the dimensions, measurement, and the distances between the structures. Kinetic evaluation is mainly assessment of mobility and vascularity. So any lesion or a structure or a normal or abnormal structure, we should tell in terms of topographic, quantitative, and kinetic evaluation. So before interpretation, we should keep in mind the artifacts. So artifacts, they can be multiple. The first one is the reverberation or a multiple signals. It can be internal and external. Internal is the one, there are reverberation is nothing but the echoes are reflected multiple times. In internal, the reverberation is happening within the structure. For example, air bubbles or a spherical foreign body, pellet, all this will cause internal reverberation. And external reverberation is the artifact occurring between the probe tip and the structure seen. For example, intraocular lens. So that is an example of external reverberation. And shadowing is nothing but we see a high reflective structure, followed by that all the structures posterior to it are not seen. So it can be of two types, like sound attenuation. That is, we see a high reflective structure and posterior to it nothing is seen because of shadowing. And the edge refraction is nothing but whenever some structures may not be seen properly because of the refraction by the edge of the lens. And enhancement, when there is a weakly attenuating, when there is a weak echo, for example, a cyst, an anophthalmic cyst, structure posterior to it may be seen as high reflective. It is not that the posterior structure is high reflective, it is because the anterior cyst is low reflective. We are seeing the posterior structure as high reflective, hence the name enhancement. Perpendicularity is that same structure, when we keep the probe perpendicular to it, you will get a high reflective echo. And if we slightly change the probe position, if it is not perpendicular, the echo might change. The intensity of the echo might change. And bumps are nothing but refraction. They are seen as masses in the superior and the inferior fundus in a B scan. This is because of the refraction of the sound wave by the periphery of the lens. It is also a kind of edge or refraction artifact. So why we should know artifacts? Because we should avoid misinterpretation. And second, few artifacts are actually, we are utilizing it to diagnose few conditions. So this is the external reverberation. This is an intraocular lens. So the reverberation from here, all the reverberation echoes, they will be spaced equally, and the intensity will reduce in a linear fashion. This is a shadowing, wherein there is a high reflective structure, followed by that we are not able to see properly. And this is an oil-filled eye, which causes sound attenuation. Again, the things are not clear here. And this is an indentation artifact, which is a form of a refraction or edge artifact. So first we'll start with lens. So this is a globular hyperreflective mobile structure in a vitreous cavity, is a dislocated natural lens. The internal reflectivity again depends on the degree of cataract. So this is also a lens, but there is an adjacent vitreous membrane. And this is a dislocated IOL, where there are few reverberations. I have put this here because the most other, so the other globular hyperreflective structure commonly confused with lens is Cysticercosis. So this is a globular hyperreflective oval-shaped cyst. The characteristic thing is the echodense scolex at the center. If it is in the vitreous cavity, the cyst may be mobile. If it is subretinal, it may not be mobile. Sometimes the scolex can also be moving also. So we are going for the differentials of dot echoes. The first is Asteroid Hyalosis. These are high reflective, grouped, clump-like echoes which move along with the vitreous with the clear space between the echoes and the posterior hyaloid. So they are high reflective and the posterior clear space is there. To see the asteroid better, we reduce the gain. Here is the -31 and it is still present. So next is a vitreous hemorrhage. In fresh cases, it will be like dot and lines. The number is directly proportional to density, low reflective, mobile. When it becomes organized, it becomes high reflective because of the inferior settling of membranes, and it becomes less mobile. Whereas in a vitrectomized cavity, it becomes diffusely homogeneous. So this is a fresh vit heme with the subhyaloid heme. And this is an organized heme with the membranes and little bit more high reflective. This is a vit heme in a vitrectomized cavity, diffusely homogeneous. And this is the same patient, vitreous hemorrhage with the vitreoschisis, which is nothing but splitting of the posterior hyaloid. This we should remember when we, because in surgeries we might encounter a second membrane. So next, the other most commonly confused with vitreous hemorrhage, especially in the setting of trauma, is endophthalmitis. Ultrasound is used to determine the severity and extent of the infection. So opacities and membranes, they appear as fine dots and lines of moderate intensity. Even membranous echoes can be present. The reflectivity is variable, low to moderate. And in the scenario where we encounter endophthalmitis, for example, in a post-operative endoff, we should look for nuclear fragments, which may be highly reflective, mobile. And sometimes in a very early end of the IOL may be causing reverberation echoes. We may not be able to see the VIT echoes. In that case, we have to slightly tilt the probe so that we are not missing any early end of. And more thicker echoes anteriorly suggest anterior locus of infection, for example, corneal ulcer. And in a post-traumatic setting, we should always look for intraocular foreign bodies. In an ultrasound, the poor prognostic factors would be choroidal detachment, especially hemorrhagic, very thick vitreous membranes, retinal detachment, marked retinochoroidal thickening, and presence of T sign. So this patient, he was a patient of endogenous endophthalmitis. It is diffuse, entire vitreous cavity is filled with echoes. And this is a post-anti-VEGF injection endophthalmitis. The echoes are more along the posterior, like the pre-retinal phase. That is very suggestive of endoph. And this is a post-traumatic endoph with the intraocular foreign body causing a comatile artifact. So Panophthalmitis, though the characteristic sign which we look for is subtenon widening or T sign. So this is a endoph with the T sign. So non-infectious uveitis, vitritis, we look for basically vitreous echoes and retinochoroidal thickening, choroidal detachment. In very severe cases, we can have exudative RD. This is a case of vitritis, low to medium reflective echoes. And it can be seen in posterior uveitis, pars planitis. In pars planitis, we should also look for peripheral vitreous opacities and lens-induced inflammation, inflammation due to retained lens material. In that case, we will see high reflective lens material in the vitreous cavity. Sometimes we can also see hypotonic due to chronic uveitis. And recently, ultrasound-guided subtenon injections are also given. So posterior scleritis, the characteristic T sign, and retinochoroidal thickening. In very severe cases, we might have serous detachment and choroidal detachment and serous RD. After treatment, we look for response to steroids, the peripapillary choroidal thickness, how much it's decreasing, so it becomes an invaluable tool. And in Vogt Koronai-Harada syndrome, there is this patient has vitritis, retinochoroidal thickening, an exudative RD with a shifting fluid, and we also monitor, as I said, PPCT after initiation of oral steroids. So in a trauma, other than that, what I have covered is we should look for vitreous incarceration and scleral wall discontinuity. And this is a foreign body with an endoph. Peripapillary choroidal. Peripapillary choroidal thickness. 0.8 to 1.2, it's normal. First is the posterior vitreous detachment. It is smooth and thin usually, thick if bloodline. The reflectivity varies from extremely low reflective to extremely high reflective. And it is usually very much mobile, like undulating movements are seen. So a complete PVD, and this is an incomplete PVD with an attachment here. So retinal detachment is a bright, continuous folded membrane with a high reflective 100% spike. And usually the mobility is less than posterior vitreous detachment, but more than a choroidal detachment. Again, it varies, depends whether it is a fresh retinal detachment or an old one, and in the presence of proliferative vitreoretinopathy. So whenever we encounter a case of retinal detachment in ultrasound, we should assess the following factors like insertion, whether always retinal detachment, there is an insertion at optic nerve head. In a total retinal detachment, in a subtotal where the extent of the RD is, we have to make a note. And configuration of the RD, whether it is an open, in a funnel RD, open funnel RD, closed funnel RD, and when there is extensive PVR, it can be like a triangular shape. All that we have to make a note. And after movements in a very fresh retinal detachment and very bullous detachment, the retina can be very much mobile. And in a very long-standing retinal detachment, or when there is extensive proliferative vitreoretinopathy, the retina may be totally immobile, fixed. And the intensity of the subretinal echoes. If the subretinal echoes are high reflective, suggestive of cholesterol or blood, it indicates a long-standing RD, and the prognosis may be poor. In a long-standing RD, the findings which we usually see are intraretinal cyst, calcification of the leaflets, as well as subretinal high reflective echoes. So this is a retinal detachment with the break here, discontinuity in the high reflective membrane. And this is a long-standing RD, open funnel, with a intraretinal cyst. So total RD is an open funnel, wavy rope-like, high reflectivity. This is a closed funnel RD. Almost there is no movement and it is T-shaped. Exudative RD, we look for mainly shifting fluid, and
Also another thing is, the subretinal hemorrhage, if you are suspecting, it will never be diffuse like this. It will be a clotted hemorrhage. So you will see some clumps of echoes. If you have a fresh subretinal hemorrhage, definitely you will see some clots or some clumps, and you will have a kind of more of a solid appearance of the echoes. Yes. If you have a long-standing subretinal hemorrhage, like you see in Coats disease or in ROP, then they will be diffuse, but they will have a more of a high reflective nature, and you will see kind of some cholesterol crystals, so you will have more shiny and more high reflective echoes, and they will also be having a very floating kind of movement. So this kind of echoes will never be for subretinal hemorrhage.
Okay.
Thickened retina with intraretinal cyst, long-standing.
Thickened retina in a long-standing detachment. That's an amazing.
Sir,
Long-standing RD? Can somebody explain to me? Call it thickened retina. You can call it either there is a vitreous which is still stuck to the retina, it is not detached yet because there is no PVD, or there is subretinal glasses which is causing this double membrane shadow. But don't call it as a thickened retina because of that. Thickened retina would have been something else.
The cyst is a little posterior, so that we suppose the movements of the retinal tissue. We also have some vitreous echoes.
So if it is grade C PVR, the folds will be thick and the after movements will be less or negligible.
What can you see?
It will be a taut membrane with minimal after movements. Reflectivity will be low in a long-standing RD.
Before you proceed, I think for the sake of the new people, can you explain what is that orange line and that orange graph that you see in each image, and what is the importance of that?
This is the actual linear A scan which process through the structures. As it passes through all the structures, the reflectivity is represented here. So it starts from the probe tip, and we can move this line and we can see the area of interest, the reflectivity we can see. In an exudative detachment, we should look for shifting fluid. So wherein we make the patient, we do the ultrasound in supine as well as sitting position. In the same quadrant, we should look for the shifting fluid. And other thing is we have to rule out Mars lesion. And the tractional RD, we should see the configuration of the RD. We should see whether it's a shallow traction or a very frank traction. This is a macular traction. And here is a tractional detachment. And we should also look for posterior vitreous schisis. And in a diabetic TRD, most of the cases, the traction is seen along the peripapillary region and along the arcades. The mobility in a tractional RD will be very less. It may be shallow also. And preoperative assessment in a tractional RD is important, as in where to make the sclerotomies, whether the PVD status, as well as the presence of vitreous schisis, all that is important. In a choroidal detachment, is a smooth, thick, dome-shaped membrane. There will be no ONH attachment. It may extend anteriorly, causing a ciliochoroidal detachment. The membrane is very thick, steeply rising, 100% spike. Double peak sign can be seen because it contains two membranes in a detached choroid with attached retina. And there will be little or no after movement. Sometimes there can be scalloped appearance of a peripheral shallow choroidal detachment, or sometimes the choroidal detachment is so high that it can be a kissing or oppositional CDs. And the choroidal detachment can be serous. Here the internal reflectivity is low, and here it is hemorrhagic, where there are multiple moderate to high reflective echoes inside. So it's a nutshell. The PVD, the attachment is variable. In RD, it's always present. And the insertion is in the ora serrata if it is a total RD. And it's a V-shaped. It can be open or closed funnel. And here it is a smooth, thick membrane. And in a low gain, RD and CD persist, whereas PVD may not persist. And the movement, it is has a marked movement, whereas an RD, fresh RD is more mobile than a long-standing RD, and CD is almost immobile. And reflectivity, it is variable reflectivity, and these two are high reflectivity. So retinoschisis, it's a bilateral, smooth, thin, sharply demarcated, dome-shaped membrane. And in a dynamic indentation, the space between the the retinoschisis RP and the sclera disappears in a total detachment, whereas in a retinoschisis, it reduces but never disappears. So mass lesions, ultrasound is a non-invasive, can be used in both opaque and clear media, helps in differentiation of various mass lesions and aids in follow-up. So in a mass lesion, we should tell about, again, topographic, quantitative, kinetic, and associated features. The topography, like location, even the clock hour and the layer involved, shape, size, and number. Quantitative, most important is the measurements. The measurements, it should be taken from the apex of the tumor to the inner scleral surface, and it should be taken in a transverse basal and a longitudinal or vertical basal. And in both the scans, the height of the tumor or the thickness of the tumor should be measured, and each of these should be mentioned in the report. And associated RD or other features we have to mention. And vascularity, intrinsic vascularity is seen in melanoma, and that also we should make a note of. So this is a retinoblastoma. Here it's a diffuse mass with calcification. The reflectivity depends on the extent of calcification, almost filling the globe, and it causes shadowing. And reflectivity depends, and it's one of the differentials of leukokoria, where the axial length is usually normal or long. And the high reflectivity persists in low gain. So this is a differential diagnosis of leukokoria and ultrasound. Usually retinoblastoma has a normal axial length. It can be reduced in ROP, retinopathy of prematurity, and PHPV. And Coats disease, it can be normal. PHPV and Coats disease are unilateral diseases, and ROP is usually bilateral. In ROP, we see total RD with anterior retinal loopings. In PHPV, we see vitreous band extending from lens to optic nerve. And in Coats disease, we see exudative RD. So this is a retinopathy of prematurity with the total closed funnel RD, and this is the peripheral anterior looping. This is a closed funnel RD. Persistent fetal vasculature, it consists of a band extending from the lens to the optic nerve head, and it causes a tractional RD in the posterior pole, usually unilateral, and the axial length is reduced. In a Coats disease, it's unilateral exudative RD with the cholesterols in subretinal space. Most importantly, it should be differentiated from retinoblastoma in that it does not have a distinct mass, and the calcium, which is very much high reflective than cholesterol. So causes of intraocular calcification, the most important, these are the most important causes of intraocular calcification: retinoblastoma, astrocytic hamartomas, choroidal osteoma, phthisis bulbi, and optic nerve head drusen. So differentials of choroidal mass lesion, the low or medium reflective, most important one being malignant melanoma, medium to high reflective, metastasis, lymphoma, and hemangioma. So malignant melanoma, dome-shaped or collar button, high surface reflectivity with low to moderate internal reflectivity, regular or homogeneous structure, and it can be associated with an exudative RD. There is sound attenuation, wherein from the high surface reflectivity, the internal reflectivity decreases, producing a sound attenuation or acoustic hollowing, also known as angle kappa, in the A scan. And internal vascularity, that fast instantaneous echoes are seen. And then we have to tell about the tumor dimensions. Other findings can be choroidal excavation, which is seen here. It is considered as an illusion and can be seen in other choroidal masses also. And orbital shadowing and posterior scleral bowing can also be present. So this is a choroidal malignant melanoma with anterior ciliary body extension also. So this is a transverse scan showing the basal diameter and the apex tumor height or tumor thickness. And this is a longitudinal scan. The measurements I have removed because it was not clear. So metastatic carcinoma, the clinching factor is the exudation. The level of exudation will be more than malignant melanoma or any other lesion for the same size of the lesion. And the retinal detachment is seen on the surface of the lesion as well. Choroidal hemangioma, it is a dome-shaped lesion with high internal reflectivity. That is a differentiating point. In a Sturge-Weber syndrome, there can be circumscribed choroidal hemangioma. So this is a patient who was initially suspected to be metastasis, and then we investigated. It was a fundus picture with the choroidal mass, FFA and ICG showing stipple hyperfluorescence. This is an OCT picture, and this patient underwent MRI also, which showed post-contrast enhancement suggestive of hemangioma. So this is a choroidal osteoma where there is a high reflective block-like lesion with the shadowing, and this is the same patient with the OCT and fundus photo. So post-surgical scenario, we can have intraocular lens, the most common finding. We can have a peripheral uncut gel, and this is a indent by the buccal and scleral buccal, and this is the indent by the encerclage. This is the indent is more, and it is being seen in a specific quadrant. Here, it is a shallow indent. It's seen throughout the globe along the circumferential extent. And this is an oil-filled eye. And here the oil meniscus doesn't follow the contour, so there can be a possible retinal detachment. And this is an air-filled eye and a gas-filled eye. Because of sound attenuation, we are not able to see other structures. So this is a Ahmed valve, where we see a bleb as a low reflective echo and the adjacent plate as a high reflective just adjacent to the sclera. So this is a retinochoroidal coloboma, is a well demarcated excavation in compared to the posterior staphylogram. It's a smooth bowing. So both can be associated with retinal detachment, here in a high myopic eyes and here in the coloboma itself. And this patient has a vitreous membrane also. The optic nerve head drusen, as I already mentioned, it is sometimes buried, may not be seen visibly in the fundus. So we do an ultrasound and to rule out a cause of disc edema. It a high reflective echo at optic nerve head, which persists in low gain. This is a optic nerve cupping. Here it is seen as a small excavation, and this cupping only if it is more than 0.7, 0.8, it is visible in an ultrasound. And this is an optic nerve head avulsion, where there is echoes radiating into the optic nerve head with the widening of the optic nerve head shadow. So this is Anophthalmos, where there is no well-defined globe structure, and this is the Microphthalmos, the grossly reduced globe. In both the cases, we should look for any cyst, orbital cyst, and its communication. In addition, Microphthalmos can be associated with coloboma. And Nanophthalmos, the eye is small in size, but the lens is normal size. And it can be associated with uveal effusions, in severe cases with Exudative RD. Measurements of the lens, like lens thickness, anterior chamber depth, can also be performed with the standoff. And retinochoroidal thickness is retinochoroid scleral. That thickness is that structure is grossly thickened. And Thysis bulbi, grossly reduced axial length, total RD or a disorganized globe structure. Posterior ocular cord calcification with shadowing is present. So it's an indispensable tool in day-to-day retina as well as normal ophthalmological practice. It's a simple, non-invasive, safe. It can be used for follow-up. It can be repeated. There is no radiation hazard. But in all the cases, we should always have a holistic approach. We should make a diagnosis based on the history, clinical findings, and ultrasound can be used as an adjunct tool. And always while interpretation, we should keep the artifacts in mind. These are my references. Acknowledgement.
Amit also.
Thank you.
Suggest if you haven't understand the class today, just go through the atlas. Our atlas is pretty good. It may have been done on a different machine long time back, but it's still very representative. Go to the atlas again. It'll take you only a few hours. Everything is there, right there, whatever she's explained in the class. All representative images. Yeah, and Janani, you speak well, whatever written, everything is fine, but the images are not representative. I know there was a problem with some backup going on. machine backup and there was no images for you in the last 3 weeks. I just spoke to Charanya. But I think we are all there in the department. You can always ask us for images which are good quality because a lot of us have done this kind of presentation long time back.
Okay, sir.
So even if it is not from the new machine, the older machine, the ultrasound is going to remain the same. The features are going to remain the same.
Yes.
Dr. Vikas has got lovely photographs of and ultrasounds of tumors. Others have also other features. So I think when the class is on an imaging modality, I think we should have good images,
Yes, sir.
lasting impressions. What you write on the left-hand side is something which nobody will remember.
Yes, sir.
What you describe on the ultrasound is something which they'll remember.
Yes, sir.
So I'm sure that was the, unfortunate thing that you couldn't get the right images. Since it was not backed up, I have no idea. I've asked Janani to find out why there is no backup for our ultrasound machine images. So anyway, good work because it's not an easy class to take.